afternoon, everybody. I realize we are missing a microphone for our special patient guests, so if somebody could bring us out an extra microphone, that'd be great. You have heard from Veenu and Josh already, and I want to introduce myself really quickly. My name is Dana Lewis. I am an ePatient. I have type 1 diabetes and celiac disease. I'm probably an odd person to moderate this panel because you would look at me and say, she obviously has a smartphone. She's getting her continuous glucose monitoring blood sugar data on her watch right now. Why on earth is she up here? I'm also probably a special case because up until I started hacking my own medical device, I did not use any apps or my smartphone for my health. I'm pretty stringent about not adding any apps to my phone because I think they're stupid. They don't do anything for me because nobody's ever designed anything that would serve me. So that's one of the reasons I was really excited to be here at this panel and why we're here to talk about this today. And so I'd love, David, if you could introduce yourself and talk about why you're here, and then we'll move on to Devin.
Sure, thanks. Hi, David Van Sickle. I'm one of the co-founders and CEO of Propeller Health, used to be called Asmapolis, and I'm really happy to be back. Interestingly enough, today to talk about technology, households where we don't use smartphones, but we use inhalers, and we bring our technology, which is essentially sensors that grab onto inhaled medications for asthma, for COPD, and monitor the use of those medications in daily life, and then try to put that information to work to help individuals improve their self-management, and give physicians and care teams windows into how their panels of patients are doing so that they can reach out and help people improve their control.
Great. And Devin, before we move over to you, I actually wanted to make a special thank you to Erin. And can we give her a round of applause for being here online and supporting this panel with her story? So Erin's presentation was actually a taped part of a letter that's posted on the Heart Sisters blog. I think they'll be tweeting out the link. I really encourage you to go read the rest of it. She'll also be engaging with you guys online who are tweeting during the panel. And next, I'd like to introduce Devin, who is a patient. And I would love for you to share why you're here, your story, and your perspective on technology.
Thank you. My name is Devin Lowe. I'm 56 years old, and I'm a resident of San Francisco. I was diagnosed with asthma when I was 11 or 12 years old. And for the next 40-something odd years and many, many visits to the emergency room, I thought that's all I had. My last emergency room visit was about 3 or 4 years ago, and that process, they referred me after that visit to what was then at the time called Healthy San Francisco, which is one of the first civic health care programs that was offered to anybody in San Francisco regardless of income. It was not insurance, but it was a care coverage program that was offered through the city and county of San Francisco. That put me in touch with a pulmonologist, and for the very first time in my life, I was in my 50s already, that I finally had access to a pulmonologist, and was rather disappointed to find out that I had COPD on top of asthma. But it answered a lot of questions about my condition. My medication regimen changed, and because of the fantastic people that I've connected with, I am sitting here before you today, very much happy with the way my life is. And so it was through that relationship with pulmonology that I met Dr. George Su, who is speaking at this conference at another panel. And through that connection, he invited me to sit here to talk about why I don't use a smartphone, I guess, as a representative of my community. I would say it's partly economics. I still hang on to a landline because I have a very affordable plan that includes unlimited long distance. Also, I'm a pragmatist. When the power goes out, my landline still works. And so in the event of emergency, I still have contacts. I frame a lot of my response to the world by the question of what happens when the power goes out. We are so wired and connected to batteries these days that when the power goes out, how in the world do you continue on? I think about, I'm going to get a manual coffee grinder, because if the power goes out, I can't even make coffee. And so I've been going to the Burning Man event for a long time, 14 years, and I learned a lot about self-sufficiency. And that self-sufficiency, what I take out there in the desert, transfers to emergency preparedness here in San Francisco. And so that issue about power is a big one. And so that's part of my mindset. The thing about the smartphone is that I do have a smartphone, and it's so very interesting that at one time, my little flip phone was like the hottest thing on the planet, a razor. And I still have it partly because of the fact that the neighborhood that I live in is there's a high theft rate for bikes and cell phones. I've hung on to my bike tenaciously, my second bike, and I still have this because I will not be a theft target in my neighborhood. That's a pragmatic approach. To move on to address the questions that's more of concern with this panel, and speaking really from my own way that I view the world, I do have an iPad, but I have an iPad only because of the fact that it was gifted to me. So I'm one of those rare ones that has one of these. I like it because it's a good size, and I use it primarily for email and information and things like that. So it's a good size. Smartphones are small, and as I get older, my eyes are not as good as they used to be. I had to take off my glasses to see things. And then on some of the phones, the little chiclet buttons were just impossible to work with. Everybody knows I hate texting because it's so much easier just to talk than to sit and push buttons and make corrections and have the phone make assumptions for you about what words you want. It's really a bother. And so that's on a pragmatic reason, as me as an aging adult with bad eyes and the lack of patience to sit and type out individual words. That's another barrier why I don't like to use smartphones and that type of thing. I mean, emailing's okay, but the rest of it. This thing about running your life through a smartphone, where everything is accessible through your smartphone, they carry your life with you in your pocket. Again, it's a theft issue, and again, it's the issue of what happens when the power goes out. When I was at Burning Man, I'm lucky enough because I volunteer for an organization very closely tied with the top org. I have power. And because I have power, I have an electrical outlet. And everybody noticed it, and all event long, I was powering other people's devices, powering up their devices. I don't have a problem with it. It's not my power. But the point, again, is that thing again about having to rely on something you need to charge up all the time to stay connected to the world.
So Devin, can
yes.
you share a little bit about your experiences with healthcare and how your perspective on being reliant on wired devices, how did that impact you learning about your condition?
I'm sorry, say again?
How did you learn about your condition if you don't have these devices because you don't want to be reliant on power? How did you get educated about your condition?
I had to go online and just do research. I think that if we're getting to the question of how I would use technology to use more, it would be really great to have access to things like my medical records and the medications that I take, and as much information as possible to help me be informed and to self-manage my condition. I understand Kaiser Permanente has a very good integrated information system that patients can access, and I think that's really important. I mean, I'll meet my care providers and they'll ask me, what do you know, when was the last time you saw this? When was the last time you had that? I don't have any of that information because none of it's ever provided to me. In fact, the way it is right now, this folder is all the information I have on my when I see my general practitioner. This is the folder that I keep all my information in when I see my pulmonologist. And this is the folder that I see when I see my dentist. And there's no reason why I should have to have all these folders around that is on me to have to know when I saw the doctor, what my medication is, and all this kind of stuff. I'm not provided with that information in a way that's easy for me to access and want to refer to. You had made, your presentation had talked about, no, I'm sorry, no, my mind just went blank. But the point is that if it's presented in a way that makes me want to go there and to see what's going on with me, then I would be much more interested in going there. Can you hold this for me, please? Oh. Thank you. Okay. Thank you. Okay, so one of the things that I liked about your presentation was that you showed pictographs. You had little people, little diagrams, charts. I think that's really, really cool. The thing, as a COPD patient, I get my numbers. I find out what my FEV1 is and things like that. and I get my numbers on my blood pressure and et cetera and things like that, but I can never remember it because there's no way for me to track it over time. And that is how I can, because I'm very, I'm informed, I keep in touch with stuff, but there's no way to track the information, and it's not available to me. Mm-hmm. So how do I know what my health is like? And so, I'm influenced by things like this is from a car magazine that I subscribe to. But the idea is the idea of charts and graphs that you can kind of just, it doesn't really matter what the statistics are. If I tell you that the big circle over here is good and the little circle is bad, you can attach anything you want to it. And the same thing with the scales over here. And so if my FEV number, if my blood pressure, if someone's LDL number, doesn't matter what it is, blood pressure could be charted in a way that patients can easily track their information. It's just like tracking the stock market or the unemployment rate or anything else.
Yeah, and that's a great point, and I heard that theme a lot, both in your presentations, whatever people have shared, and what you just said right now, is the way we want to track things aren't the way that things are tracked. And I think that's one of the challenges, is that we are not being designed with, we're being designed for, and that means we can't always use the solutions. It's obviously not working. So I'd love to hear your thoughts on how can we design with patients? When you're working with solutions, your community health worker is a great example. How do we find these people, and how do we proactively set up the system so that these people aren't aberrations, but they become the norm?
I'll start with a really simple answer. I mean, if you look at our job description for our senior designer at Medic Mobile, number one, their main responsibility is to be best friends with community health workers. And our entire team walks alongside our users, so we're not just saying design with people. Mm-hmm. It's at every point in that product development and implementation and did that work process, it is the right choice. And so it has to be that way. And a complicated diagram showing what's going to be happening in a health system doesn't work, but pictures do, and playing card style interactions do. So I think when you take a principle like that and you just keep changing and experimenting with the methods, you land on things that work, and it always tends to be when you're designing with somebody in solidarity. Mm-hmm. Yeah.
Yeah, and I would just add, we're doing a program now where we're teaching frontline safety net providers how to use human-centered design thinking and the methodology. So I think it's very much in line with what Josh was talking about. But I think we have to listen and hear the users. I think oftentimes the entrepreneurs just haven't been going to the settings where vulnerable populations are and really understanding what the needs are. And I think that's the secret sauce, is just knowing consumer better.
So, David, from your perspective, what could somebody do to reach the populations that you work with? What have you seen that works and what doesn't work, and what would you love to change?
Yeah, maybe 50% of the folks in one of our commercial programs actually don't have a smartphone, and we use a regular cell phone, or we use a hub, a home base station, essentially, to help gather information from the world and bring it in. But I think it's a little bit beyond sort of what qualifies technology in a given household, and it's more about how can you come to a population with a gamut of opportunities and build something that extends an infrastructure to them. Sometimes you're making a product for caregivers who do have a smartphone, even though the actual patient might not. Mm-hmm. Sometimes you're building a product for a care management team who might have a smartphone, but might work in communities where there isn't a large prevalence of smartphone ownership. So I think there's some, from the company's perspective, being able to come to a healthcare system or delivery system and sort of encompass the range of variability there is pretty important. Obviously, you don't want to be creating a solution just for the person who has the latest iPhone, but there's lots of opportunities to build technology that serves that whole population. It isn't specifically related to smartphones.
Definitely, and Veenu, you spoke about that a little bit, like talking about designing for people who have something now. I mean, how can we encourage more people to think about the now and what works now versus, okay, here's what we'd like to do, so we're going to design for that?
Yeah. I mean, I think it goes back to, David raised that point too, is having options. So I think it's great if we feel like, the future, we have to be designing for the future and not for the now, but thinking about options for people today, I think, is really important, especially when we know 91% of people have a texting-enabled phone. Like, why shouldn't we be able to leverage that? So I think, it's really about giving options. There's not a one-size-fits-all, but to have it be just a smartphone-based solution is not going to work for most of the patients we work with.
And Devin, I'd love to know your experience. Has anybody ever approached you and talked to you about your experience and asked to design for you? And if the answer is not, how would you like somebody to approach you, and what would you say to them to work with them?
Okay. I would say that, for starters, access has to be across all platforms, which I heard discussed already. And it has to be created in such a way that the patient feels like they are invested in wanting to get onto this site and to be involved. I mean, the weird thing about self-management is how little of it really happens. And I think a lot of it has to do with the fact that people aren't equipped well enough. The only reason why I manage my COPD as well as I do is because I really grab for information and I collect it all. And I have to write notes that describe which addresses my COPD, which one addresses my asthma, which one's corticosteroid, all these sort of things that I shouldn't have to work out for myself. I love the idea of the pharmacy papers that now have the little pictographs and things written in English. I had made this comment that, you look at your bottle of medications and they're great for everybody but the end user, because you can't look at the bottle. I laid out 4 bottles of 4 different things and they all look the same. And if I didn't know what they were for, poof. And that's why people don't take their medication. And so a lot of it has to come down to making it accessible, making it easy for the patient, however, through visuals, colors, numbers, pictures of animals, whatever. It needs to be set up in such a way so that the people who go to the public library, or the people who have language issues, or people who have learning disabilities can still be able to access things through very common forms of communication like color, shape. And so to develop a site that will draw people in, here's my information, here's when I last saw the doctor, so I can be informed that when I go to see the doctor, I know when my last visit, I know what my numbers are, I can track them. And the best thing about being able to track them through time is you can feel good about yourself when you're making progress, especially something like an LDL number.
Mm-hmm. So I have to jump in and say that is the most tweetable thing and the most shareable thing I've ever heard, that most technology solutions are great for everyone except the end user. And it has to be the exact opposite of that if this is going to work and actually improve health outcomes. And you figure out your value proposition diagram and you have your customers and all of that, but starting with the user, I think is the clearest message. It's a great quote.
And also, just to carry on with a different perspective of that, I have issues when it comes to, I'm a very visual, tactile person. I like textures, I like shapes, I like feeling differences in the things I touch. The problem with touch screens is all you're doing is you're touching a screen, and there's kind of a barrier between reality on the other side when all the reactions you get is nothing. I liked it when smartphones started vibrating when you pushed a button because it reacted. Mm-hmm. So I come from a world of working with wood, working in theater with lighting instruments. They're 3-dimensional, you can move things. And so for people who live in a tactile, visual, 3-dimensional world, that screen becomes a real barrier to just connecting with a process. I mean, I get myself into trouble by touching a button. I get myself into further trouble by touching another button. And, God is Control Z, if God is there listening to you. So that's really frustrating for somebody like me who has a problem sometimes taking concepts hidden in computers and making them 3-dimensional and real.
Yeah. And so I'm curious, there's a lot of programs that are focusing on third world countries or underserved populations externally. I'm familiar with a program in Seattle called Global to Local, which takes a lot of these technologies and tools and applies them in a community in Seattle that has statistics and disease statistics that are very similar to some of these populations we would see elsewhere. And I'm curious if you guys have any thoughts or experiences on how can we take what you're doing right now, you figured out what works, these community health workers, all these things. How do we apply it in our backyard, in the communities that we're in right now? What can we learn from that to take away today?
It's a great question. So on the last slide, when I say any clinic anywhere, I actually mean that, and the US is included. I will say that our first 2 R&D projects and tries in the US, that was the 21st of 21 countries. So it really was everywhere else first. It's a lot harder. And I would say it was 4x the resources and time to get those up and running. It's a rough estimate, but around 4 times. So as a nonprofit or a technology company that's allocating resources for maximum impact, that's a pretty difficult multiplier. Also, and some of those trials had great results, but in one of those cases, we were the 33rd IT system. There were 32 existing IT systems, and we were the 33rd we were asking providers in clinic to use. And from our perspective, it might have been the only one out of the 33 that was of any use to anyone, but it doesn't really matter for those providers. So again, starting with the user and their perspective, some things need to get sorted out first. And I think focusing on utility of systems to end users is a really good place to start. I think the other 2 things we need to have in place are community health workers connected to formal health systems, and we're working with the Public Health Institute in Oakland to do a scan and figure out the different names and systems that are set up for CHWs. So that's something we're really interested in. And the other is for US healthcare systems to be set up to reward and really be designed for better outcomes and better efficiency, because it just hasn't been the case until recently. So there's exciting shifts as well.
Yeah.
And I would just add that I think, just building on what Josh said, I think it is an exciting time, because I think the incentives have been what's been getting in the way in many ways. We're running this Texting for Better Health program. It's been going on in the rest of the world for forever. We know it works. But now finally the clinics are saying, we're capitated, or now we're at risk for these patients. And access is such a huge problem that we're going to absorb those costs because we're losing patients. We finally care, we're competing, and patient experience is important. So some of those drivers are shifting, which I'm hoping are going to allow some of these technologies to come forward. I was talking to this physician who's created this really interesting business in Bangladesh, which basically helps get people access to docs through text. So basically, they're texting with their docs, and they're like, people in the U.S. are crazy about privacy. They rather live and be able to talk to a doctor than worry about privacy. And so, there's just some cultural shifts that are going to be changing. And at some point, it feels like it should be up to the consumer to decide that.
Yeah, I think that's a great point. And one of the things I'm wondering is, with our doctor-centric culture, where the doctor tells us what to do and we do it, we don't necessarily drive our care. How can we work with providers, the average healthcare provider? None of you guys are average, you're exceptional. But for the provider, how do we work with providers in the system of now, where we've got all these challenges? How do we get them to take advantage of some of these systems or start using them? Again, it might be the 33rd one that they're using, but how do we get them to start adopting it, and how do we get patients to be able to ask for it and get it?
I would say that it begins, like I said earlier, with providing them with the information. It's like, if you want patients to be invested in their own health care, they need to know what's happening with them. I find it really kind of ironic that, like I said, I had to do my own research to find out what I'm putting in my own body. Why should my doctor have all the exclusive access to that information and not freely share it with me? If you want me to be a partner in my own health care, then reach out to me and say, let's work together. Here's what I know. Here it is. Let's talk about it. No one told me that the corticosteroids I took was going to cause me dry mouth syndrome that was going to cost me all my upper teeth. No one said anything about that. I had to find that out by myself, and anecdotal information from people whose children were losing their teeth from asthma medications. And that's a string I had to put together. And when I told my dentist about it, she didn't even know about it. Whoa.
Yeah, that's powerful.
So how did I end up becoming the primary investigator in my own health care?
That's powerful.
So that's what I'm saying. If you want to reach out to the patient, then these websites that need to be connected through whatever platforms, through smartphones, have to say that mentality of the doctor is being in charge. I know that this is changing, but that thing of the doctor has to, maybe there's a mentality of holding on to information. I know there's, like, even between information platforms, people don't want to give up information. Doctors don't want to share it with other, because they feel, oh, this is ours. But, I am not a thing to be manipulated, and that's what I think this whole thing of patient-centered outcome is all about. I am not a thing that gets run through a system. If you want me to be an active participant, then involve me, inform me, make the information available to me interesting and compelling so that I want to look at those statistics. So I either want to feel good about myself or say, look, there's a deficiency that I need to talk about because the numbers. I have no idea what my numbers are. I only know, I don't know.
Right.
Maybe why not show something about what my blood pressure is and what's normal, because I can never remember.
So I'd love to, if there's any burning questions from you guys on Twitter, you'd like to come to the mics, I see one right there. Please go ahead and speak your question.
Thank you very much, and I'm so taken by Erin's introduction to all of this and want to return there as you kind of conclude, because what Erin addressed was something we hear across communities, and that's that being an underserved population is more than just not having access, but it's about a level of depression that really affects activation. So we have this evidence that says that those who are in higher levels of poverty don't have the same educational opportunities, just aren't as active of patients. It's always hard to see because we have such exceptional e-patients always here at this conference. But it suggests to me that there's this larger issue that we have to address. I'd love to hear your thoughts about how do we get to a depressed community that as a community has to deal with such poverty that issues about blood pressure seem unimportant, and we just can't get them involved.
Who would like to tackle that? David, any thoughts?
Well, I'm interested actually in a point on that, and also on what's been spoken earlier, which is I think there's also another conduit for information collected from these types of technologies, and that's to engage the broader community, right? It doesn't always have to just go back to an individual, but it can be about making visible some of these contextual and upstream factors that we know to be important, socioeconomic determinants of health. Creative Commons, I think, just got an interesting proposal funded by the Robert Wood Johnson Foundation to make public art installations out of environmental exposure data being collected on the ground in Louisville. And I would love to see that extended into health and outcomes, so that broadly, like when I did work in India, right, you see in some communities, you actually see sort of the community health tally on a chalkboard, right? And there's a little bit more shared awareness of what the level of health and disease is like, what the activities like across the community. So hopefully there's ways to put data to work there to broaden knowledge and understanding about what's happening.
Yeah, and we've received some questions on Twitter that kind of bridge the point that you're trying to make in terms of patients who are not as engaged or the depressed community or whatever. Somebody wants to know from Twitter on the hashtag MedX, if you'd like to tweet in your questions, but how can those of us with lots of tech and resources connect with those who are not actively in tech? And a kind of parallel question to that is, Devin, are you on Twitter by any
I am
chance?
not.
So we have a request for you to sign up for Twitter so people can tell you how awesome you are. So maybe somebody can help you do that.
Okay, I'm going to need help with that.
You can't be on
Yeah.
the no
To be
smartphone
honest with
panel,
you,
though, yeah.
to be honest with you, I am influenced by a lot of the feedback I hear from people who get on Twitter and people on Instagram and all this. I'm a very private person, and so that's why I don't engage in those kinds of things. And I hear about the social fallout from people who get on Facebook, and the people who get on Twitter and things like that. I control my message, and I just like I want to control my image, and so, that may change, and I'm going to do it very cautiously because I'm not going to get caught up in anybody else's firestorm or anything else like that.
Yeah, that's a great point. And so anybody who would like to tell him how awesome he is, if you don't catch him in person, please feel free to tweet me and I will pass along the message to him so you can control it. We're running out of time, but one statement of how do you think we can engage with get the very connected, very tech users to engage with the non-tech users? One sentence to close.
I don't know.
Talk to me. Ask me questions.
Go for it.
I'm here. It's just kind of understanding what the dynamics of the community are. It's going to be very hard, but it's a good place to start with public libraries, and through children, through people's patients. Maybe their kids might introduce them up through that way. But a library is a great place to start, and just understand that there are people who are never, ever going to use smartphones, who are going to have very limited computer technology and will only approach it if they feel it's inviting and has something to offer them. Because otherwise, if it's foreign and it's like, I can't make sense of this, you'll lose them, and they'll never go back.
Not a sentence, but very well said. And Veenu and Josh.
I mean, I would encourage, if you are in your local community, find your community health centers, your public hospitals. That's how we found Devin, was through San Francisco General Hospital. These places are open. They want help. They are looking for help for their patients. And if you need help finding those clinics, come talk to me. I'm happy to connect you.
My favorite definition of community is a group of people who care more about each other than they have to. And I think there are a lot of communities and a lot of offline communities. That's the reason we've seen uptake of mobile tools all over the world by community health workers. There are millions of community health workers who go door to door and say hello and cover care for 2 billion people right now. And so if that network weren't in place, then the uptake of the tools wouldn't be there and the technology wouldn't matter. So I think if we start by mapping and understanding people who are those central points in offline communities, we can make progress.
Yeah, and that's a great note to close on. MedX is an example of a community, the online communities we're all a part of. And so thank you all for being here, for engaging with us, and for caring more than you have to. Thank you.